But it's really nice to see such great community engagement here in El Dorado County. Groups like this are the groups that really help keep the fabric of a community together. And so Mindy and I are really proud to be here and applaud you for doing this every month. So a little bit about Marshall. I think a lot of folks know that, we're the hospital on the hill in Placerville, but we're really much more than that. We're a large integrated health system, independent of anybody else operating in El Dorado County. And our vision is a world where everyone can achieve their highest desired state of health and well-being. We see our relationship with the patients that we serve as collaborative. We want you to tell us how you want your health to look, how you want to live your life, and then we're going to work with you to try to achieve your goals. So a little bit about us. Mindy's going to go into this a little bit more. In fact, she and I had a coin toss over who got to use this photograph. So some of you will remember that back in the 50s, right after the end of World War II and in the ensuing baby boom, the Hill-Burton Act was passed, and a lot of facilities, especially in California, were built leveraging state and federal dollars under the Hill-Burton Act. So the community would raise money, and then they would get matching funds, and that allowed a number of facilities to be built in the late 50s and early 60s. So we were organized in 1957. We currently have a 111-bed general acute care hospital in Placerville. We are a level 3 trauma center. You'll see some of our designations on the next few slides. We have approximately 1,500 employees and over 150 allied physicians at Marshall, and we have some 17 outpatient primary and specialty care clinics. So we've grown a lot from that initial 11-bed hospital that was built in the 1950s. And these are some of the specialties, and Mary mentioned our new clinic in El Dorado Hills, and I'll talk about that in a little bit. But this is a pretty broad variety of specialties that you don't typically see in community or rural health systems. And we're able to do this in part because of our location. We're just close enough to the urban areas to be able to attract and retain clinicians, providers, nurses, and the staff it takes to run a hospital, but still distant enough to have to do this on our own. So everything we do here, we do out of operations. Again, we're not affiliated, we're not part of a large health system. We do have some strategic partnerships, and I'll talk about those in a minute. One of the things I learned a long time ago when I started my journey in community health and hospital systems is that bigger is not better. Better is better. And so when you're looking for where to get your health care, what you really want to look at are the measurable outcomes that can be demonstrated by the accreditations that a facility has, by the outcomes that are measured by their auditing facilities. So these are just a few of our awards. The Lowen Institute, that's a big deal certification for a hospital. We got an A on that. Leapfrog is another one that a lot of consumers are familiar with. We got an A safety grade from them. And then again, just more of the same. We see here we've got a primary stroke center certification. That's a really big deal. And you'll see some of the years go back to 23 because that's the reporting year. So I know that it's calendar year 25, but the most recent reporting year for most of these entities is 2023. And then we talk a little bit about the numbers. El Dorado County is roughly 190,000 people countywide. We serve the entire western slope of El Dorado County, and that's about 50, 60,000, depending on who's counting. So you see our total patients served in fiscal year 24 is almost 63,000, almost 37,000 emergency department visits. That's in 1 year. Outpatient services, that includes diagnostic imaging and labs and our clinic visits, is $156,000 plus $189,000 for clinic visits. So we're busy. We see a lot of people and we take care of a lot of people, and we consider all of those people our people. So again, thank you, Mary, for mentioning this. So our newest facility is in El Dorado Hills. If you're familiar with the former Blue Shield campus at the corner of Latrobe and Highway 50, we purchased one of those buildings when Blue Shield sold the property, and that's where we're located, and we're really excited about it. It's a beautiful facility. We've built out the first floor. We have primary care, we have specialty care. What we're really excited about is our same-day orthopedic care and same-day primary care. So if you have a minor injury to a bone, if you've fractured a foot bone, or you think you might have broken something in your hand or a small fracture in your arm, you can avoid the emergency department altogether and go straight to this clinic. We have x-ray, we have casting, we have labs, we have all the services that you would need to be taken care of in that facility. And if it is a true emergent medical case, we will boot you back up the hill to the emergency department. But otherwise, it's a much faster way to be seen and be in and out. And then we have a beautiful rehabilitation and sports performance center in that building. And Mindy's done a really great job, along with some very generous donors, of outfitting that. And I know we'll hear more about that in a minute. So my presentation to you today is a little bit of past, present, and future. We did a little bit of the past. I want to talk a little bit about our economic impact. This is the present. So Marshall is a healthcare provider. That is what we do. But we have an impact outside of our health services. We are one of the largest employers in El Dorado County. In fact, we are the largest private employer in El Dorado County. So a couple of years ago, I commissioned an economic impact analysis report. I wanted to be able to quantify what the economic impacts are of Marshall in our community. So we brought in Dr. Varshney from Varshney and Associates. Some of you may have seen, if not him, his work. He's done a lot of this kind of work in the region. And he did a forecast for us that includes impacts, including the greater Sacramento area, because like water, we don't stay in one place. We flow to where the people are. So our dollars flow into the Sacramento region as well. Dr. Varshney uses the IMPLAN model, which is standard nationally. If you are going to do an impact analysis, you are going to use the IMPLAN model. And we looked at 3 focused activities. We looked at our capital investments. We have a bunch of those. Our expenditures to operate Marshall, it's not cheap, is the headline, and the public benefit generated by Marshall. And so I had summaries of this whole economic impact at the door as you came in, so if you want to grab one of those on your way out, please do. And that really summarizes what is otherwise a very dense document, but that document is also available. So if you have more questions about the economic impact analysis and would like to see it, I'm more than happy to send you an electronic copy. But our indirect and direct and induced benefits is over 10 years to produce more than $5.4 billion, that's billion with a B, of economic output, creating over 27,000 jobs. And again, that's not just Marshall, that's our impact going out in concentric rings into the community, resulting in nearly $2.4 billion of new labor income and more than $3.2 billion of new value added to the county. The tax revenue, so we are a not-for-profit. We're a 501c3. That means that we don't have shareholders. We don't have investors. Our community gets back the dollars that we make above the cost of operations in the form of new services and new capital. So if you look at the increased taxes on production and imports, which is a standard model in the in-plan model, and I know I'm getting kind of wonky here, if you look at our direct and indirect and induced impact, the tax revenue benefit is over almost $3.5 million a year in El Dorado County. So we are contributing, even though we're a not-for-profit, not taxed entity. When I pay Mindy salary, she pays taxes on that salary. She buys things in El Dorado County, there's taxes on that. So overall, we're contributing about $3.5 million in tax revenue, even though we are not directly taxed. So a little bit about Marshall, and I love that picture of our patient with the blown up hand gloves so much I have to put it in every presentation. So want to talk about the current state of healthcare. I know there's a lot of questions about that. There's a lot of uncertainty right now. I'm not going to have every answer for you, but I am more than happy to take questions back and get answers to your coordinators so that they can be disseminated if I don't know the answer. But to say it's an interesting time in healthcare would be a deep understatement of what's happening right now. I want to talk a little bit about my leadership's philosophy. Siri Nelson is our CEO, and by the way, she extends her apologies. She is the president of the California Hospital Association this year. She's at a board meeting and couldn't be here, but wanted to be. But her philosophy is we don't keep reacting to every single thing that happens in the legislative environment. If we did that, we'd make ourselves crazy. What we do is plan for future eventualities based on what's the reality today. But we don't keep knee-jerk reacting to things that may or may not come to pass. So that's sort of our philosophy. We have a strong strategic plan. We fire on that strategic plan every single day. We measure whether we're achieving that strategic plan every single day. And by sticking to our knitting and by doing the things we do well and getting our patients taken care of, that keeps us on the right track. So what's happening nationally? All right, nationally, things are not so rosy. Hospitals' financial performance right now is impacted from a number of drivers. And this is national, this is not the state, so I'm not going to talk about California-specific things on this slide. But overall, there's a decline in patient volumes. This is completely predictable because we do more and more care of patients outside of the hospital's four walls. We take care of patients through telehealth. If you've ever had a phone visit or an app visit with a physician, that's outside of the hospital's four walls. If you go to a clinic, that's outside of the hospital's four walls. And more patients are getting the care they need in their own homes, whether it's virtually or by delivery or self-management. So it's understandable that the patient volumes would drop in acute care facilities or hospitals. But what is happening is that the patients that we're then seeing in the hospitals have a much higher acuity. They're sicker, they stay longer, they're more expensive, and their mortality rate is higher. So we're really mindful of that dynamic as things change in healthcare. And rural hospitals specifically are challenged with older patient populations, greater percentages of Medicaid patients, and challenges in recruiting providers. Again, Marshall is one of these sort of frontier facilities, if you will. We are close enough to the Sacramento region that we have to compete with Sacramento for staffing, for nurses, for doctors, but we're far enough away that we don't get all the benefit of being in a large urban area and the volumes that that brings. So we're doing an interesting dance there in terms of we're not rural, but we're not urban, but we're also not suburban. We're something in between all of that. Our trade organization, the California Hospital Association, calls us a tweener. We are definitely in between all the things. HR 1, otherwise known as the One Big Beautiful Act. So this is what's been in the news quite a lot. I know there's a lot of questions around this. Keep in mind that a lot of the impacts of this legislation won't actually be felt until 2027 or later. Some of the cuts don't go into effect until later, and so this gives hospitals and communities and states some time to plan or change the course of things as the case may be. But what we do know is that an estimated almost 3.5 million Californians will lose access to Medi-Cal, which is our version of Medicaid. And I think what's important for people to understand is when they lose their insurance, they don't stop getting sick. And they still come to the hospital. Unfortunately, by the time they get to us, it's often much more expensive care because they've delayed care because they don't have insurance. So getting patients proactive, preventive care is really the best way to drive down the overall cost of healthcare. But right now, if people lose access to their insurance, then chances are they're not going to be going to the clinics for their regular annual checkups, but they will eventually land in our ER if they get sick. And if they can't pay for it, then we absorb that. And that's not just Marshall, that's every hospital. There are certain services that were previously allowed under Medicare or Medi-Cal, for instance, telehealth services. When the COVID pandemic hit, everybody remember COVID? Does it ring a bell? When that pandemic hit, the Centers for Medicaid and Medicare Services, who oversees Medicare and Medicaid, in their wisdom, and this was very smart, said we need a waiver that will allow people that provide telehealth services to be paid for those services. Because, dirty little secret, we weren't getting reimbursed for telehealth services. We were providing it, but we couldn't bill Medicaid for it or Medi-Cal. So during the telehealth waiver, during the pandemic, we were actually able to bill for those services, so we could pass on some of the costs that we were absorbing along the line to the insurance companies. Those waivers ended September 30th, and because we went into government shutdown, there was no opportunity to extend them. So we're back in this zone of, well, it looks like we're not going to get paid for telehealth, but we know we still really need to provide it, and our patients really want it, and we really need it to reach our remote patients who can't travel. So around and around we go. But just know that that was something we could do that we're now not going to get paid for, but we're going to continue to do. And then there is still some uncertainty regarding some programs that were mechanisms that allowed the state of California hospitals to leverage fees that they assess themselves to get matching dollars from the feds to improve reimbursement rates. I know it all seems crazy. There's nothing about healthcare finance that makes sense to anybody, but this is not an uncommon scheme. In fact, 47 of the 50 states all use some mechanism like this in order to improve their reimbursement for Medicare and Medi-Cal. They weren't doing this to improve their bottom line for profit. They were doing this because hospitals don't get reimbursed the total cost of providing care. So for example, at Marshall, roughly 60% of our patients are Medicare, and roughly 25% of our patients are Medi-Cal. And Medi-Cal and Medicare patients, both of those cohorts, we get paid 70 cents on the dollar of the actual cost of care. And we're not going to turn people away because they're Medicare or they're Medi-Cal, but we are going to lose money on every single patient that walks in the door with one of those two payers. So another dirty little secret of healthcare finance is that it's the patients who have commercial pay, who have a good plan outside of Medicare or Medi-Cal, who are actually footing the bill for all of the rest of the healthcare system. But if you're like Marshall and you've got this sort of imbalance in your payers, you're never really going to quite make it up on the end game. Have I confused everybody?
No. Could you repeat those statistics? 50%, how many?
Yeah, so our payers, our payer, what hospitals refer to as your payer mix is the percentage of your gross charges that are attributable to a certain payer class. So for Marshall, we have 60% Medicare and roughly 24%, 25% Medi-Cal. We have about 16% commercial pay. The rest is a hodgepodge, and some of that is charity care and bad debt. So I mentioned that scheme for leveraging federal dollars because under H.R. 1, that money, some of that money is going to go away, but we don't know yet which programs are being eliminated and on what timeline. We spent the last year and a half fiercely advocating for protection of some of those schemes, and we're not clear yet what's going to be protected and what's not. So the range of what could be impacting California facilities is between $66 and $128 billion with a B to California hospitals. Are we having fun yet? Would you like to be a CFO for a community hospital? All right. I don't know if the battery just went out on this. Bill, you want to just hit the next slide? Thank you. So nationally, it's estimated that 37% of hospitals are losing money, and that's year over year. That's not just the most recent year. In California, we have 23 hospitals that are identified on a watch list for being on the brink of closure. You might have just read that the hospital in Blythe just filed bankruptcy. There are other hospitals along the Highway 395 spine that have already closed or are almost closing. Merced, of course, closed about a year and a half ago. And these have very real impacts. They have very real impacts on the communities they serve, but also on the neighboring communities. If something were to happen to Marshall, and nothing's happening to Marshall, the hospitals in Sacramento would be deeply impacted because people have to go somewhere to deliver babies, to get their care, and that means those hospitals that are already impacted then become more impacted. So if you think you have a wait line now in some of those facilities, wait until more community hospitals close down, and then it gets really bad. So it's a snowball effect. You want to give me the next slide, Bill? Thank you. So now I'm going to pivot a little bit to the state. So last year, the voters of the state of California authorized Prop 35. And Prop 35 was a variation on the theme of taxing ourselves to leverage more federal dollars. This one was approved by the voters, but the governor still clawed back some of those funds of approximately $6 billion. He is clawing back $1.6 billion because there's a shortage in the California General Fund this year. And so in order to balance the budget, he's clawing back some of that money. While that's happening, we also are still getting more regulations, yay! So, most regulations that are passed with the honest intent of protecting patient safety, ensuring good patient outcomes, and making healthcare more accessible. Those are noble and worthy goals, and we agree with them, but they don't always play out that way after passage. And so an example of that is SB 596, that just was signed into law last week by the governor. SB 596 essentially dictates how we do nurse staffing for on-call nurses at the hospital. And while we had a system that worked great and allowed us to have flexibility to move nurses from one unit to the other as needed for on-call, now we can't. And the cost of this is going to be another $500,000 to us annually. And again, it's well-intended, but it's bad legislation, and this is the kind of thing that hospitals have to deal with pretty consistently every year. And then we have the Office of Healthcare Affordability, and excuse me, I don't mean to be glib. The Office of Healthcare Affordability, again, was well-intended. It's a department of the state of California that's new. It's established to reside under the Attorney General's division, and it's designed, or its intent, is to reduce the overall cost of health care to make health care more accessible to more Californians. But we don't understand any of their methodology. It makes no sense, and essentially what they're trying to do is cap growth. Now, if I pivot back to our new clinic in El Dorado Hills, that clinic is designed to help us access more El Dorado County residents, to provide more services that are in demand. But under OCA's proposed rules, we would not have been able to do that. And we're actually driving down the cost of care there, because if you go to that clinic when you have a minor orthopedic trauma, you are not going to pay as much as if you went into the emergency department to get that same care. So we're driving down the costs. We're accepting all insurances. We are making it as easy as possible to not have a huge copay. And this clinic was designed to achieve all those goals. But it runs counter to what OCA's dictates are. So it's, again, well-intended, but really poorly executed on behalf of the state of California. And then the last thing I want to talk about on mandates, I'm going to spend a little bit of time on, which is our seismic compliance. Bill, you want to hit the next slide? I think I expand on that too. We'll keep going. That's just bad news. One more slide, please, Bill. So back in 1994, how many of you remember the Northridge earthquake? Yeah, it was pretty bad. And by the way, today's the anniversary of the Loma Prieta earthquake. I was there. That was fun. So after the Northridge earthquake, and this is real devastation, that is a Kaiser clinic that was destroyed in that earthquake. The state of California passed Senate Bill 1953 that said, we know that hospital facilities have to be built to the highest standards, and we're going to up that ante. We're going to make it even stronger. So when Senate Bill 1953 originally passed back in 1994, we had until 2005 to meet this seismic mandate, where all California hospitals had to upgrade their existing facilities. This was unfunded, however. There was no money for this, nor was there any consideration for where your hospital is located. So you could be in a very seismically active area, like Santa Rosa, Los Angeles, or you could be in a not seismically active area, like, I don't know, like Placerville. But it didn't matter. Everybody's going to get held to the same standard. So through a lot of lobbying efforts on behalf of our advocacy and trade organizations, we were able to get that deadline extended a few times. The final extension was the year 2030. But that gave hospitals like Marshall time to do things that were really vital. So a couple of things that we did. We've spent over $70 million so far in meeting this mandate. We built a new 4-story building on our campus. It's where our emergency department and our kitchen and cafeteria are all housed. That's our newest building, and that was built to meet this mandate. We've also invested in our structures so that they met the 2020 safe and standing metric, which means that our facilities are not going to collapse on our patients or on our nurses and doctors. So we've met that standard. But the 2030 standard says that not only do we have to have all of that, we have to have 3 days of water, gases, fuel. We have to maintain all systems operational in the hospital, not just critical services, but all services, for a minimum of 3 days post a major seismic event. So for hospitals like Marshall, that means adding more fuel tanks, adding second and third and fourth generators, each one at a cost of $300,000 apiece. It means doing a lot more to meet this seismic mandate. And I will just editorialize on this a little bit. When I drive up to Marshall, I'm not thinking about earthquake, I'm thinking about fire. If I was going to want to harden the facility for anything, it would be for fire and evacuation. but we need to spend this money to make the mandate work. And the Department of Healthcare Services, which is the agency in California that tells us whether or not we can have a license, has said publicly that they will pull licenses for hospitals that have not complied. So this is serious, it's law. The governor made it very clear, no more extensions, no more exceptions. Everybody has to meet this by 2030 or be significantly underway to meeting it. Next slide, please, Bill. Thank you. So I've talked about all that. Next slide. So where are we now in terms of seismic? Well, we're meeting all of the milestones that are required by the state of California on the path to 2030. We have our designs in process. We've been meeting with the engineers and the architects. We know what we need to do, and the cost is around $40 million to do the last few stages of work on the campus. $40 million is a lot of money, even though we've already spent 70. We'd really rather spend that $40 million on other things. But we don't have a choice. This is something we're doing. So our board of directors is currently analyzing what our options are for financing the final phases of work. But this is just, again, one of those challenges that you have to deal with as a hospital. Next slide. Okay, I'm going to try to get into some good news here, I promise. So next slide, please. So let me end on a high note here, if I can try to pull us out of this nosedive. So there are new models for healthcare that we think are very promising and that we think will help deliver care for the next 60 years in El Dorado County. First is AI. You're hearing a lot about AI. We are very grateful that some bills were passed this year that prevent the use of AI for approving medical services by insurance companies, for denials or prior authorization. Those things all have to be seen by human eyes. And we're grateful for that. We don't think AI is quite there yet. But AI is very helpful in helping us to reduce physician burnout, which is a very real thing. And we do that by allowing AI to do the scribing with the physician. So while they're in the exam room with you and they're talking to you, artificial intelligence is recoding the conversation, summarizing the key notes, putting the information in the right places, and that's saving physician time from them spending their 7 p.m. to 9 p.m. hours doing all that coding and catching up on that. There is more focus now on ambulatory care and preventive care, and that'll help keep patients well and out of the hospital, and really that's our goal. We love our hospital, but we'd much rather see you in our outpatient setting than our inpatient setting. We are really investigating a lot of robust patient management and telehealth services that helps patients take care of their health in their home with the help of caregivers and clinicians, and prevents all those unnecessary trips to clinics and to hospitals. Oops, that's okay. And then finally, strategic partnerships, and we talked about this a little bit. So we do partner with folks in the community. El Dorado Community Health Clinic is a strategic partnership for Marshall, as well as UC Davis. We have an affiliation with them in our cancer center so that we can offer things like clinical trials, virtual tumor board that otherwise would not be available for our patients. So those are strategic partnerships. They are not financial marriages. So UC Davis does not own us. They don't own any part of us, but this is an affiliation that allows us to enhance the services we provide in our cancer center. And we will always be on the lookout for the right partnership, but Marshall feels very deeply and very passionately that we can best serve you when we are independent and when we're not part of a larger health system making decisions in a faraway place. So with that, I know you've heard enough from me, and now Mindy gets to deliver all the good news.
Do you want to do questions now on your part?
Yeah, so, oh, thank you. So Would you like to have any discussion now on this stuff before we pivot to Mindy, or would you like to do Q&A at the end? I've stunned them into depression and silence.
Okay, then I'll just take over.
All right, take over.
All right. So my presentation is relatively brief. I'm the good news part for you. So I am the executive director, as Mary said, of the Marshall Foundation for Community Health, which is the philanthropic and fundraising arm of Marshall. So the beginnings. Maia talked a little bit about the beginning of Marshall Hospital. It was a community effort, and it was funded by philanthropy. It was started by the community with the addition of the state and federal funds that were obtained from the Hill-Burton Act. The community needed to raise $411,692. I want to find out who gave those $2. That I'm very curious. Today, it would be $125 million equivalent, the amount it took then and what it would be now. And I got the straw that had the Lions Club, and I figured it was appropriate because this building, I had the Lions Club. They were integral in helping raise funds for Marshall. So Marshall was started by the community and for the community. It's built on a pear orchard donated by Michigan Cal Lumber Company, which was the largest employer in the county. And we thank them every day for giving us that land for us to have Marshall. It was named for James Marshall, and it opened in 1959 with 49 beds and 12 physicians on staff. You heard what Maia said, we've come a long way, baby. So why is philanthropy important? Well, for 65 years, Marshall has been the largest not-for-profit community health provider on the western slope of El Dorado County. Marshall was started by philanthropy, by the community, and we're very, very good stewards of the funds that are entrusted to us. We take donor intent very, very seriously, and contributions go really far at Marshall Foundation for Community Health. And why? You'll hear a little later how we aligned with Marshall, the health system. They are covering all administrative costs, and they're helping underwrite the foundation so that the dollars that come into the foundation go back to their intended purpose. We're also having a broader reach to grant-making institutions. El Dorado County has been overlooked. Grant makers have given in Sacramento and in Placer. We are really trying to show the value of investing in El Dorado County. So the foundation started as the Marshall Hospital Foundation, and there is the list of our initial trustees. You might see some familiar names in that. And the board met quarterly for lunch. And its first year raised $37,000. Later on in the presentation, I'll show you where we are to date. And bought $19,000 worth of equipment. Gosh, I wish equipment was that cost now. And then we had remaining funds of $18,000. So in 2002, the board voted to expand the name from the Marshall Hospital Foundation to the Marshall Foundation for Community Health to reflect the investment that the foundation was making in the community and in community health. At that time, the fund balance reached to almost 1.2 million and had an endowment of $835,000 and some expectancies through planned giving of $633,000 from 9 planned gifts. Wills, trusts, charitable remainder trusts, charitable gift annuities, and all of those modalities. So in 23, the Marshall Foundation for Community Health Board voted to form a stronger alignment with Marshall. I won't say it was easy. Change is hard. It was very, very difficult, and it took over a year from 22 to 23 to do this alignment. But since that time, we have been able to really reduce the expenses to the foundation. Marketing is covered by the health system, accounting, legal services, they cover the audits. So it's really strengthened the philanthropic arm so that we're able to give more back to the community, more back to Marshall, and be more efficient. And our current assets exceed $4 million. So in 25, these are just a few of the areas that the foundation granted back to the community, from small grassroots nonprofits like Bears by Your Side, who make small handmade bears that they give out to children in need throughout our county, and also for Marshall programs such as the Daisy Award, a dementia training for our staff, and some of the initiatives that Maya had spoken about, like our baby-friendly initiative. So this is the trajectory of the funds raised over the past few years. So in 22, the foundation raised a little over $500,000. And this last fiscal year that closed, our new fiscal year starts October 1st. We raised $1.3 million in support of Marshall and the community we serve.
Hey, Mindy, when were you hired?
I took over the foundation in 23.
Just noticed.
So some of the things we funded, Maya spoke about the 0G. This is so cool. We are the only health system that has a 0G 3D physical therapy piece of equipment west of Salt Lake City. This is helping put Marshall on the map. What this is if someone has a stroke, or if they're having trouble walking, or if they've had an amputation, it's a machine that goes in the ceiling, is adhered to the ceiling, and it's a harness. So it takes the weight off so that rehabilitation can happen faster and better and easier. And it's in 3D, because last time I looked, we all don't walk just in a straight line. We move in all directions. So this piece of equipment will allow rehabilitation. So if you are a pickleball player, it'll allow you to move like you're playing pickleball. So it's really, really exciting. And anybody that wants a tour of our El Dorado Hills building, I'd be happy to share that with you. And it's going to be installed November 7th, 8th, and 9th, and we're going to have a big party, and you're all invited. The ambulance awning. When I arrived at Marshall, I was troubled to see that patients were coming in an uncovered ambulance area. So patients were subjected to the rain, the snow, the sleet. Like the paramedics are not postmen. They need a cover. The patients need a cover. The families need their patients to have a cover. So the foundation raised the money. It was matched by the hospital, and the ambulance awning has a beautiful cover now, so that the paramedics and the families, those that are delivered to Marshall, don't have to be delivered in inclement weather. The El Dorado Hills expansion, the board voted to provide $1 million in funding to help underwrite that new facility. And then, as always, we continue to give back through community grants. So some of the initiatives that we're working on, we have an amazing new spine surgeon who's been with us a year, Dr. Green. Patients are coming from outside of our area in order to have surgery by Dr. Green. He's fantastic. And the foundation just voted to fund the spinal ENT navigation system. What that means is spine surgeries will be less invasive. They'll be quicker. The recovery time will be better. And it will help the physician navigate, so when they have to put screws in your back, which sounds horrible, but they'll do it quicker, easier, this is the latest state-of-the-art technology. We're raising money for an empath unit. We were speaking to the woman from the El Dorado Community Foundation or Community Health Clinic. I'm sorry, I can't recall your name. Carol. We were talking about the increase in behavioral and mental health in our community and in society in general. We are building out an empath unit, which is a place that patients, if they're not having a life-threatening injury or illness, they're not an extremis, this is going to be a place that is specifically designed for individuals that are suffering from withdrawal, substance use disorder, mental health, 5150, behavioral health, any kind of issue that is not life-threatening. When patients come in now, we have to strip the room, take everything out so they won't be a harm to self or others. We have to have someone watch that patient. And emergency personnel are not trained in psych. They're trained to save your life. So we're building a special unit designed to take care of these patients in the proper setting, with the proper equipment, with the proper providers. And I'm very excited about that. And then we're raising funds to add an additional PET CT scanner in Cameron Park so we can see more patients. A mobility park in El Dorado Hills so that patients, the 0G 3D is fabulous. But you know, once you get off that harness, you kind of have to go back out in the real world. So the mobility park is going to have uneven surfaces, stairs, areas where you can walk, where you can learn to walk like you would outside instead of being in a physical therapy space. We're redoing our cardiac cath lab, expanding it, and adding more equipment. And once again, always the funds that we raise that we give back to small grassroots nonprofits in the community. So why philanthropy? Well, it means the love of humankind. It actually doesn't mean fundraising. Philanthropy is a love of humankind, and that is what the Marshall Foundation for Community Health brings to each and every resident of our county. And gratitude is healing. Grateful patients want to give back. You heard Maia's talk about operating margins. I won't go into that any longer or any more, but philanthropy is here to help where operations might not. And Marshall was started by the community, for the community, and wants to be here in perpetuity for generations to come. And that's my story, and I'm sticking to it. I'm sure you have no questions for me, so I'll give the mic to Maia.
No, don't you dare go anywhere.
There's only one name on the printout.
Oh, that's Maia's report. So, thank you so much for bringing that up. So, my name is Mindy Danovaro, and I'm the Executive Director of Philanthropy. She asked what my name was, and she asked why there was only one name on the report. So I gave her my name. And Danovaro, D-A-N-O, V as in Victor, A-R-O. Okay, so there's also a little something I want to share with you. I gave handouts from our annual report. So it's a little bit of a game because I grabbed the wrong box. I grabbed the one that had typographical errors in it. The printer, I guess they must have used those old printing machines where you had to put the letters in one at a time, and they forgot some. So the challenge I have for each of you is as you read it, see how many of those mistakes you can find. And whoever finds them all will win a prize. You don't have to do it now. My name is Mindy Danovaro. I'm the only Mindy at Marshall, and you can find me, and Mark knows where to find me too. So, all right? Any other questions?
A question related to, I read an article, it was the Bee or the Wall Street Journal a couple of weeks ago about the shortage nationwide of GPs.
Yeah.
The question was about the shortage nationwide of GPs.
Thank you, Vanna. Yes, it is an issue everywhere. It is. So there are a couple of ways that Marshall is addressing recruitment at Marshall. El Dorado County is a beautiful county. It has access to a lot of amenities that a lot of providers would like to take advantage of. So we need to be really mindful of how we tell people about what our hospital is. If we just tell recruitment specialists that we're a community hospital in Northern California, that doesn't really sound all that fun. But when we tell them, this is El Dorado County, this is what we have going for us, this is what's happening in our community, this is where your recreation is, this is our proximity to Sacramento, to the wine country, to Tahoe, we have to sell it a little bit. But the shortage isn't just for GPs. There is a shortage for pediatricians, for family medicine, and neurologists. Oh my gosh, neurologists. So what Marshall is doing is partnering with all of the academic medical centers in the Valley to make sure that we're getting residents that are cycling through Marshall. So it takes more time and more energy from our providers because they have to proctor these doctors, these baby doctors that are coming up. But the flip side of that is that we're introducing those doctors to Marshall, to Placerville, to El Dorado Hills, to Cameron Park, and showing them what practicing in our community looks like. So it's a recruiting tool for us as much as it is an education tool. But there's also disparity in recruiting for nurses, and right now just people that are sub-licensed but clinical folks. So I'm thinking about people that are laboratory techs or radiation techs or medical assistants. Marshall, a year and a half ago, started down a journey with El Dorado County Office of Education to open an MA school. So we actually have a school on our hospital campus that we collaborate with EDCO to bring in students twice a year and graduate them as medical assistants. We've had tremendous success with that, and we continue to do that. It gives us the chance to meet new students and hopefully recruit them if we like them and they like us, while it also fills a need in the community. So we're looking to expand that to possibly lab techs and then radiation techs or pharmacy techs after that. If we keep building on that program, we can see opportunities for aligning more strongly with the academic medical centers for recruitment.
There was a question over on this side.
I was just going to ask, how are you getting along with UC Davis now that they're building in Folsom?
How are we getting along with UC Davis now that they've built in Folsom? Well, so all of the big systems are building in Folsom. It's a really good question. And we have a very strong relationship with UC Davis. They host our electronic medical record. We're affiliated with them, as I mentioned, for our cancer services. But they're like any other large organization. It can be unwieldy. And we try to divvy up the care in the way that we can. One of the reasons we opened that orthopedic outpatient clinic is because nobody else is doing that. So Sutter's not doing it, UC Davis isn't doing it, Kaiser, Dignity, they're not doing it. Now we've got a niche. That's sort of how we have to do it. We're still always going to have to compete with them, even though they also provide services.
Yes.
I have some probably geeky, not geeky questions, but I'm interested in your economic.
The economic impact analysis, yeah.
A lot of the numbers are woven into the greater Sacramento area. I was wondering, do you have a report that kind of pulls out, just in our community, some of those numbers?
So the question is about parsing some of the data from the economic impact analysis to just El Dorado County. I can send you a copy of the full report. It's dense, and I'm happy to do that. But not every piece of data is granular to El Dorado County. Some of it, because by nature, like sales tax, we're able to demonstrate the value to El Dorado County pretty clearly. But there are other impacts that are just by their nature always going to bleed out of El Dorado County. So I encourage you to take a look at that. I'll email it to you, and then if you have questions, we can follow up. Sure.
What is the situation with the OB and childbirth departments?
Oh, thank you. What is the situation with the OB and maternity, or as we call it, the birth center, birthplace? So that is a service line that a couple of years ago we had a big transition for. We lost the OB group that had been contracting with us, and we had to find another OB group, and it took a while to get that new group established, get them normalized, and start seeing folks again. It is stable. There are still some improvements we'd like to see around those services, but in terms of delivery and OB services, everything is good. I think if you're experiencing something different, I'd love to have that conversation with you. Yes? Okay.
There was a question, if she's, are you, is she?
Oh, I have another question when it's my turn.
Okay. Ma'am, you were next.
Oh, well, I wondered if the hospital future plans for building a nursing care facility for patients that go from the hospital
Yeah.
to somewhere else? Because what we have now is an embarrassment, disgusting.
So,
pathetic.
so the question is for post-acute care and skilled nursing facilities. Marshall does not have any plans right now to establish a skilled nursing facility. That is something that we partner with, not officially, but with Western Pines and the Slope. And I take your comment to heart. I understand what you're saying. That's not on our immediate plans.
Thank you.
You're welcome.
Sorry. You were talking about the impact of reductions to Medicare and Medi-Cal, and I know but how about the Affordable Care Act? And because that falls into that kind of private sector, or is that sort of an in-betweener? I know people are already getting really hit with dramatic increases
Yes.
in terms of premiums, and how is that something that you guys
Yes, so the Affordable Care Act, the impacts around Medicare and Medi-Cal was the question, and where does the Affordable Care Act fit into that? The Affordable Care Act is about essentially Medicaid. It is a Medicaid program. When the states have their exchanges, it's primarily for Medicaid, not exclusively. Not exclusively, no. But like Covered California has, I think the greater percentage is for Medi-Cal patients. We are seeing big forecasted changes on the exchange in Covered California as well as nationally. I can't speak to where that forecast will actually land. That's beyond what we have privy information to at this point.
Well, then I have another question.
Okay, let's see if there's anybody else. All right, thank you. Yeah.
Just sort of a follow-up.
Yes.
Because you said that you can't react to everything and you have a strategy. So is your plan that you're just going to see everybody, see how much in the hole you get and try to get money to fill up the hole so you can provide care, or is there?
Yeah, let me respond to, so I'll repeat the question, tell me if I get it wrong. So the question is around Marshall's business plan and our strategic plan, and is our plan to just keep seeing everybody and get essentially further in the hole? Our plan is to grow out of this, not try to cut our way out of this. So when I talk about opening El Dorado Hills, that was a strategic initiative specifically to counter effect the impacts and the reduction in inpatient visits, the poor reimbursement that we have for those visits. So expanding and growing in outpatient care to balance the rest of the care that we provide, not get rid of the rest of what we provide. So when I talk about El Dorado Hills as a clinic, that's not instead of our hospital in Placerville. It's to help lift the boat for the hospital in Placerville. And by getting more patients who have commercial insurance into our outpatient clinics where reimbursement is better, that's one strategy to lift the boat. But our goal is not to just react to every piece of legislation by cutting staff, letting employees go, reducing services, cutting services. You are seeing that in the state of California. There are hospitals that are doing that, and especially I think the larger systems who have multiple facilities, they may close or reduce services in one facility, but that's not our approach. Our approach is to grow, to meet the future, not shrink from it. Does that help?
So you're going to try to cover all the needs of patients by doing this fancy footwork.
Well, so Marshall's, yeah, so we are going to continue to see all the patients that come and present to us. Our independent, not-for-profit mission is to serve the communities of Western El Dorado County and the surrounding areas. So when people present, we serve them. That's essentially the model.
So if I could expand on that just a little bit. So that was one of the strategies with El Dorado Hills. people up in this part of the county, they know Marshall. They are familiar with Marshall. It was built by the community for the community. We found that in El Dorado Hills, even though we had a presence there in the business park, it was not as well known as we wanted it to be. So by building or expanding that facility there, to Maia's point, we've already acquired new patients through people that didn't know Marshall, walked in, were so impressed with the care they received, they actually switched their care to Marshall, or got a primary care, but learned about Marshall and decided to come over and be a Marshall patient. So that's part of the strategy, and we've seen it has started to work. We are making more noise, we are having more visibility in that part of the county, and that part of the county is one of the parts of the county that is growing. So that is part of the strategy, because we remain tried and true to Placerville and to this area, but we have to do whatever we can to make sure that we can provide the services to everyone. And that expansion is one of the ways it's going to help us achieve that goal.
I think Mindy used great language for this recently when we were talking about our payer mix. That percentage I gave you earlier, 60% Medicare and 25% Medi-Cal. To Mindy's point, when we get more commercial pay patients in El Dorado Hills and in some of our other clinics, that balances our portfolio. So we're not getting rid of the investment in Placerville, right? We retain services there, but we're balancing our portfolio and lifting up the numbers that way.
I said it's like asset allocation for your investment portfolio. One of the other things, we've also found that with people learning more about Marshall, they're more inclined to come up the hill for their care when they see how great we are and they see the care that they can get and the personalized service that we provide. They're more inclined to go to Cameron Park or to Placerville. If they don't know anything, the inclination is to go down the hill. Yes?
Oh, I was curious about your empath unit.
Yeah.
And is that, do you coordinate with the PUF, I think it's still called the PUF unit, that Health and Human Services offers. Is that in place of that, or is it coordinate, does it coordinate with that? It sounds very, there's some elements that you described that sound very familiar or similar.
So the question was, will the empath unit replace the PUF unit, or is it similar? This is a new model that is being established. We saw one that they actually have at UC Davis, but we know that Marshall can do better. I'm not as familiar with the PUF unit, so I'll let Maya address that. And empath stands, I can never remember what it.
Yeah, emergency psychiatric access to health. It's something like that. Yeah. So when we're talking about the PUF unit, we're talking about the psychiatric small unit that the county runs up in Placerville. That's a very limited clinic, if you will. It doesn't have a lot of beds. They take a very narrow scope of patients. The empath unit is really part of our emergency department. And what we're seeing more and more, and again, this is not just Marshall, this is everybody, we're seeing more and more emergency psych patients present in our emergency department. People that are in psychiatric distress, an emergency department is one of the very worst places for them to be. It's loud, it's clangy, it's clattery, there's bells and whistles and noise all around. It's not a great... And the lights never go off. It's not a great place to be if you're in psychiatric distress. So the empath unit provides an isolated unit that is attendant to but not a part of the emergency unit. They come in through emergency. If they are appropriate for empath, they'll be escorted into empath, where it's a quiet, comfortable, trust-building environment where we can de-escalate their psychiatric emergency, ensure that if they have medical issues that we're addressing those as well, and then help that patient find the next place they need to go to, whether that's inpatient psych somewhere else, or whether that's getting them home safely, whatever that looks like and whatever the timeline is that's appropriate for that patient.
The one thing I neglected to put were the dollar amounts. The empath unit, to put an empath unit, is $2 million. So it's not without a cost, but it is the best and the right way to provide that care. Bed placement is taking quite a bit of time. That sector is overtaxed, and so patients that need inpatient psychiatric care can stay in our facility for like 3 days. So this is also a way to free that bed up, because if you have a patient that needs placement that's in an emergency room bed, in the emergency department, it's taking a bed from someone who may have a life-threatening illness. So it's another way to help us with our throughput of our patients in the right place at the right time.
I was wondering, do you have I assume there's an auxiliary group of women that have an auxiliary there. Are they planning anything in the way of fundraisers to assist with
Yes.
some of these?
Do you want to repeat the question?
So the question was, do we have an auxiliary? And are they planning on doing fundraisers? Yes, the auxiliary does give back and does fundraisers for Marshall. They have scrub sales and shoe sales and purse sales. They do fundraisers. But as you probably have noticed, volunteer membership is declining. And our auxiliary, which used to have over 100 members, is down to 25 or 30. So that's something that's also impacting hospitals. Volunteers don't want to volunteer the way they did. The days of the pink ladies and the candy stripers are a thing of the past. Volunteers now don't want to come in every Wednesday and sit at the registration desk. They want to come in when they want, or sit where they want, or maybe they want to be in a place where we can't use volunteers. So unfortunately, the whole volunteer structure, service clubs are hurting, auxiliary is hurting. It is a challenge.
Thank you.
But we could use more, so if anybody here wants to
Yes.
volunteer in the auxiliary, we'd love to have you.
We do still have a volunteer coordinator, and we're always looking for volunteers.
I just wanted to give you a witness to support the empath unit, because I used to be one of the mental health psychiatric emergency specialists who assess at Marshall Hospital in the ER, and then you have to put them in the back of the police car. And
Right.
It totally traumatizes the patient. So having something there is, I endorse and support.
Thank you. I should have given you the mic for that testimonial. So she was saying that she used to do the intakes and do the assessments, and this really is something that's sorely needed in any emergency department, and she did the work at Marshall. So thank you for your service to
Yeah.
Marshall and to our community.
Yeah, thank you.
Yeah. Does the community, does your foundation, Marshall Foundation, does it get involved in addressing needs like that, like contributing money to building that type of psychiatric unit?
Absolutely. We are in the process of raising the money to put the empath unit in, so that is something that we're actively fundraising for.
I just had a question. You had a reference to the HR1, the big bill. I kind of remember the discussion back in early summer when the Congress were, about ready to pass that. They were saying one way to offset the cost is that now they're going to, quote unquote, crack down on Medicare and Medicaid going to non-U.S. legal people. Is that an issue up here, or is that
So the question was,
for some Congress people?
yeah, thank you. So the question was HR1, and some of the discussion at the time was that any cuts to that would be made up for by kicking patients off the program who were not here legally, who were using the service illegally. That actually wasn't a thing. If you are non-resident, you don't have access to that. So that was not the driving issue here. Now, there are some things that, I don't know if any of you have heard our Congressman Tom McClintock speak, like at the chamber luncheons or what have you. But one of the things he felt very strongly about was ensuring that people that could work, who were able-bodied and could work and were taking Medicaid, should be able to do that. And so that is one of the ways they're looking at sort of cleaning the roles out, is you can have this if you're working, but if you're able-bodied and not working, then you can't have it. I think part of the challenge with that for some of our patients will be the paperwork and the bureaucracy of proving you are who you are and proving the job that you have and having to do that every quarter or every 6 months. So we may still see some attrition from the roles just due to the kind of the bureaucracy involved in that. Mary?
I'd like to give a plug for Dr. Green. Dr. Green came into this community March, and I have a spinal issue that 2 other international surgeons had opted out of. They wouldn't touch me.
Yeah.
He walked in, and he said, "We're doing this," and he fulfilled it, did it beautifully, and all of the operating room staff loved him, because I checked before I let him touch me. And so I can't say enough about Dr. Green.
Well, we will pass that along to him, Mary. Thank you so much for that.
Thank you.
Anybody else? Have we just healthcared you to death here? Beaten you about the head and shoulders with healthcare? Yes.
I seem to kind of remember that in California, there's some kind of law that says that no hospital can turn away an undocumented person who shows up in the emergency room.
So that's, yes, so what she was asking is there a law? It's actually a federal law. It's not a California law. It's called EMTALA. It's the Emergency Medicine Transfer and Something Act. What EMTALA states is that if you are going to receive federal dollars, so if you take Medicare, Medi-Cal, or Medicaid, you cannot turn away a patient that presents in your emergency department. So you can turn patients away from clinics and from other places, but you cannot turn them away from your emergency department. And EMTALA is taken very seriously. Marshall's mission is to take care of everybody. So we would do that, EMTALA or no EMTALA. We would take care of everybody that presents.
And that includes not only undocumented, but uninsured.
Correct. It includes undocumented and uninsured. We don't actually ask for proof of residency when people come.
If you show up at the emergency department, you will be treated.
Yeah. But if you can, go to the same day clinic instead. It will save you money and it will save you time. Anybody else? Well, thank you so much.